So in part 1, we talked about the receptors and the different kinds that we have. In this part, we're going to talk about what is known as the neural pathway in the sensory system, which basically means now that we've activated the receptor, how is that action potential going to reach the sensory cortex? Okay, so the sensory pathway is basically an ascending pathway. It would have to ascend the spinal cord, go up to the brainstem, and then go to the thalamus. So the thalamus is a part that is found in the brain. It is, you want to think of it kind of like where all of the sensory information would have to go through, and then from there would be sent out to the different sensory parts of the cerebral cortex. So every single sense would end up going to the thalamus with one exception, and that is smell. So smell will go from the nose through the olfactory nerve straight to the olfactory cortex. Every other single sense that you can think of will ascend through the spinal tract, ascend through the spinal cord, through the brainstem, and then to the thalamus. And then from there would go to the different parts of the cortex. So if it was vision, the thalamus would send it to the occipital cortex. If it was general senses, it would be sent to the parietal cortex and so on. That ascension does not happen with one neuron. It happens through the combination of more than one, at least 3 neurons. Some have more, but we're going to go with the least, which are 3 neurons. So the first neuron, that is the one that its receptors were activated, and then it will take the action potential to the second neuron. The second neuron actually crosses over to the opposite side. And then the third neuron, where that starts at the thalamus, would go from the thalamus to the cerebral cortex of the opposite side. So let's say we got pricked by a needle on the left hand. That information will go to the cerebral cortex of the right side. Okay, so like I said, we have to cross over in order for the sensory information to be transferred to the opposite cerebral hemisphere. And not only do we go to the primary cortex, we also have what are known as association areas of the cerebral cortex, and that is for more complex integration. So I'll show you these examples. Each of the lobes of the brain has a different association area. So we have a frontal lobe with its frontal lobe association area. The parietal lobe, and that is the lobe of the general senses. The general senses will all gather here in this gyrus known as the post-central gyrus. This right here is your parietal lobe association area. So this primary somatosensory cortex will feel the pain, but in order to analyze the pain and give it, say, a number from 1 to 10 or a grade or on a scale and so on, that would really be through these association areas. The occipital cortex, we have our visual cortex. That's where we see. The occipital association area, that's how we interpret what we just saw. Now for the temporal lobe, and that's on the side, that includes the auditory cortex for hearing, and then the auditory or the temporal lobe association area. That's how we understand what we just heard. The insula, you can't see the insula in this view. You'd have to really remove the temporal lobe in order to take a look at the insula. So an association area is, again, a deeper or a more sophisticated interpretation of these different senses. So your primary somatosensory cortex, that is, again, where you experience the different senses, but the more sophisticated and deep understanding of these different senses would happen through the association areas. The association area that is closest to the primary cortex will give you some understanding of what you just sensed, but then, memory of things that come back to you because of that sense, or different emotions or reacting to that sense, are all due to the fact that senses go to a lot more than just one association area. For example, if you hear a dog growling, okay, so you can hear with your ear, but you are also seeing with your eyes that you're watching this on TV, okay, so there's no real danger. You are not going to really respond to it, okay? While on the other hand, if you were walking at night in the middle of nowhere and you hear this growling dog, now you know you're in danger. So your other association areas are kind of picking up other stimuli, giving you that sense, I'm actually in danger. Your emotions and your response to that will be a lot more different than had you been watching this on TV. So this is all up to not just the fact that you heard, so not just the temporal cortex hearing and understanding that it's a dog, but your other association cortexes, other association areas are integrating a lot more data as opposed to what you're seeing, what the circumstances are. What are your experiences for being alone at night with a growling dog? How would that turn out? And so on. Maybe a previous experience that you had, bringing back these memories, and so on. So again, your primary cortex are really to feel different senses, but the association cortex is for a deeper level of understanding and how are you going to emotionally and physically react to these different senses. So what are factors that affect our perception? So let's first off understand that there's a difference between a sense and a perception. So a sense is something that you feel, hear, smell, or taste. But the perception is, how did you interpret that? Okay, so for example, we could all see this flower. Some of us are going to perceive it as a beautiful flower. Others are going to perceive it as, oh, that's an ugly flower. Okay, so our perceptions are very different depending on a lot of different things, and these are the factors that would affect our perception. So for example, our personalities, our emotions, our different experiences. Well, maybe somebody got stung by a bee while they were by a flower that looked just like this one. So their perception of this flower is not going to be a very positive one. Okay, so you can see how emotions and personality and experiences can really affect how people perceive the exact same thing differently. The adaptation of sensory receptors, okay, and even the adaptation of the afferent pathways. So that sock that I've been wearing since this morning, for example, I no longer perceive it as being there because I sensed it when I first put it on. Due to sensory receptor adaptation, I no longer feel it. I don't have a perception of that sock anymore. Not all stimuli give rise to a conscious sensation. So there are different stimuli like changes in blood pressure, changes in oxygen levels. All of these are stimuli that are being picked up by receptors on the inside of the body, but we really do not have a conscious sense of it. Okay. Another thing to think about is that some stimuli are out there in the outside world, but we don't have receptors for it. So, for example, there are radio waves surrounding us, but we don't have receptors to pick up those radio waves, which would be pretty cool though, but that's not the case. Another thing that affects perception are damaged neural pathways. A very common phenomenon that happens to patients when after an amputation is known as phantom limb. So the limb is no longer there, but the patient still perceives it as being there. So they will tell you, and it is very real to them that they do feel pain in that amputated limb. They can feel the numbness, they can feel tingling sensation, although they know that the limb is no longer there. Sometimes different drugs can affect how we perceive different things. So for example, let's say I'm in pain right now without any medications. I am going to give it a scale of 10. If I take pain meds, okay, although the pain is still there, but my perception of the pain is less because of the effect of the drugs. Some mental illnesses, like schizophrenia, for example, also change how we perceive things. So schizophrenic patients sometimes have visual hallucinations, auditory hallucinations. So although there is no stimulus happening, they are perceiving that they are receiving these stimuli. Now, what about somatic senses? So somatic senses are the general senses. Special senses gets a different part of this chapter. So right now we're going to be focusing on, in this portion, on somatic senses. And these are the senses that you pick up from skin, skeletal muscles, bones, tendons, and joints. So what kind of things can we pick up from skeletal muscles or tendons or joints? These are positions. Okay, so are your muscles contracted or relaxed? Is your knee flexed or extended? So if I ask you right now to do this little tiny experiment, shut your eyes, close your eyes, and tell me, are your biceps muscle, is it contracted or relaxed? What about your right knee? Is it flexed or extended? You should be able to answer these questions without looking or without feeling your muscle tone due to or thanks to these somatic senses. Okay, you can open your eyes up now if they're still closed. And that is known as proprioception. So right here, proprioception is the awareness of the position of your body parts and their movement. Okay, so that is also part of somatic senses. Touch and pressure is another example. Temperature, pain and itch, and they tend to kind of go together. So the same receptor picks up both pain and it also picks up itch. It was thought in the past that they have the exact same neural pathway because they share a receptor. We are finding that that is no longer true. So although they still share a receptor, but we think now that they might have different pathways. So that's just a mention, kind of like in your textbook. So I'm going to go ahead and mention that. But again, they still share that receptor, or at least that's what we know as of now. So these are the different receptors that pick up different somatic senses. Remember, these are not only found in your skin. We're giving skin as an example, though. We have enlarged this part of the skin. You can see the epidermis and the dermis. For each of these different receptors, you want to know, obviously, the name, and you want to know what does it pick up, okay, and if they're slow or rapidly adapting receptors. So the first one are these Meissner corpuscles, and as a general rule, bigger receptors are going to adapt very fast, while smaller receptors, like this one right here, will adapt very slow. Okay, so going back to these Meissner corpuscles, these are rapidly adapting receptors and they pick up touch and pressure. These receptors right here they also pick up, those are known as Merkel's corpuscles. They also pick up touch and pressure, but they are slowly adapting receptors. These gray nerve endings, these are the nerve endings. There's nothing very special about them. They're very boring nerve endings. These pick up itch, and they also pick up the pain. So they're also known as nociceptors. So you'll find that term as we move on. Nociceptors are the same as the free nerve endings, and they pick up pain. And you can see here that these are the only receptors that really go all the way up into the epidermis, and that's why paper cuts only cut the epidermis. They don't usually involve the dermis as well, but they are very painful because we do have these free nerve endings in the epidermis. Now, these big green ones, those are Pacinian corpuscles. Because they're big, they're rapidly adapting, and those pick up vibration and deep pressure. Last but not least are these Ruffini corpuscles, and these pick up stretch. These are slowly adapting receptors. Now, what is the cellular pathway of pain? Pain is obviously an important issue when it comes to medicine, so we want to understand how is it that we transmit pain to the brain. Well, remember the receptors were those free nerve endings. We called them nociceptors. We can find that these are the nerve endings right here. And remember, we also mentioned that in order for any sense to go to the brain, it would have to cross over, plus we have at least 3 neurons. So in the case of pain, we do have 3 neurons. This right here is your first neuron. This is your second neuron. The second neuron would relay in the thalamus, and that is your third neuron that goes from the thalamus to the somatosensory cortex. You can see here that the neurotransmitter between the first and the second neuron is substance P. P mediates pain, so the more substance P, the more pain. Or glutamate, and glutamate is actually inhibitory to pain. Now, pain, as we mentioned, we have these nociceptors, and those are your free nerve endings, and they could be stimulated by different things. So they could be either, mechanical damage to the area, let's say a punch, for example, or extremes of temperature, so very cold or very hot temperatures can lead to the stimulation of these pain receptors. Exposure to different chemicals. Examples of chemicals that we have in the body that can lead to pain are histamine, cytokines, and prostaglandins, and those are released in inflammation, and that's why areas that have inflammation or cell injury tend to be painful because of the release of these chemicals. Now, referred pain is where there's an injury to one part of the body, but you feel the pain in another part of the body. Okay, and that we're going to go into detail in the next slide, so I'm going to leave it for now. Hyperalgesia is the increased sensitivity to painful stimuli. So something that might not be very painful before getting a burn can be extremely painful after getting a burn. So hyperalgesia is very characteristic in severe burn injuries, where again, touching your skin before a burn wouldn't be painful, but after a burn, that could lead to severe pain, and that increased sensitivity to painful stimuli is known as hyperalgesia. Pain is not only a factor of how many receptors you've stimulated or how much the receptors were stimulated. It also is related to different things like to emotions. So is that person depressed? Are they anxious? Are they stressed out? It is also related to previous experiences, expectations of the situation. So for example, waiting for that needle as you're getting a shot, okay? So pain, again, is not really the factor of activating the receptors, but it also has other factors that kind of play into this experience of pain. Now, this is when we'll get into more detail about referred pain. Before we do, I want to go back and review what a spinal nerve is. If you guys remember, a spinal nerve would have 2 roots. One of them is dorsal, and that's your sensory root. We also have a ventral, and that is a motor root. They combine together to make this very short spinal nerve. Then the spinal nerve starts to branch out and supply different parts of the body. In this case, where a patient has a heart attack, okay, so the damage is in the heart, but they are feeling the pain on the skin covering the chest or the skin of the upper limb. So why is it that it's in that particular part of the skin? It's not just any random piece of skin. That is because both the heart and that part of the skin share that same spinal nerve. Okay, the brain is used to getting painful stimuli from the skin, but it is definitely not used to getting painful stimuli from the heart, and that confusion leads the brain to refer the pain back to the skin. So the brain is confused, and you feel in the dermatome, so that part of the skin is known as a dermatome, and that dermatome has to share that spinal nerve with the injured area. So again, it's not just any random piece of skin in the body. It is that same dermatome that shares the spinal nerve. Here you can see different examples of referred pain, and a couple of them I think are really interesting. So we already went over the heart attack pain, referred pain, where again, the skin over the chest and the skin over the upper limb on the left side. Another really interesting referred pain is the liver and the gallbladder. So the liver and the gallbladder are on the upper right quadrant of the abdomen. Sometimes they would refer their pain to the right shoulder and to the right side of the neck. So the patient comes in and they're experiencing this pain in the neck or the right shoulder, and sometimes we tend to think of it, maybe it's a muscular problem or it's a arthritic problem with arthritis and so on. While if you don't get a good medical history, it's hard to pick up that, that was a gallbladder attack that has nothing to do with your shoulder or your muscles. So again, a good medical history is really important in order to identify these referred pains. Now, what about pain management? So pain is literally painful, okay? And it's not something that is fun. Patients definitely, it's a red flag, and patients come in for pain management all the time. Now, analgesia is what you want to do. Okay, obviously you want to pinpoint what the cause of the pain is, try to manage that. While doing that, you want to manage their pain levels too. And that is known as analgesia. Analgesia is the selective suppression of pain while the patient is conscious. This is very different than anesthesia. So in anesthesia, the patient is unconscious. They are unaware of their surroundings. They cannot perceive the pain because they are unconscious. Analgesia is different, where the patient is still conscious, they are fully alert, but they are no longer experiencing the pain. Couple of things that we give. So the most common is obviously pharmacological agents like NSAIDs, for example, Tylenol or Motrin. NSAID stands for non-steroidal anti-inflammatory drugs. So these are drugs that help with inflammation. So they are anti-inflammatory, and they're not steroids. So they're non-steroidal anti-inflammatory drugs like Tylenol. The generic name is acetaminophen, or stronger drugs like morphine. Okay, or sometimes, remember, we have our endogenous morphine that we make in the body. Sometimes we try to stimulate them, for example, using acupuncture. Okay, that would activate the endogenous endorphins. We can sometimes stimulate the different parts of the CNS through electrical stimulation. A process known as transcutaneous electrical nerve stimulation, or TENS, where again, you're giving like these little tiny electrical stimuli through the skin. When you overstimulate these receptors, that would lead to their adaptation, and they will no longer pick up pain. Trying to think of this as we do the same thing, okay, on a very reflex kind of way. We don't electrify ourselves, but we do rub an area of pain. So if you have a part of the body that is painful, we tend to rub that area. That rubbing is overstimulating the receptors. They will go through this little very brief period of adaptation, and that will lead to a temporary relief or temporary analgesia. Now, itch, as we said, is very much related to pain. Okay, like they share the same receptor. There is, though, evidence that they don't use the same pathways, and we're not going to really worry about it until scientists kind of figure out exactly what the differences are. Just know that there are differences. And due to the fact that pain and itch are related, a lot of times you have patients that come in and they say, you know what, the scar of that surgery where I had surgery last week, it's no longer painful, but it now is itchy. That is actually a very good sign, provided that the scar is clean, not oozing anything, and it's not red or hot and so on. So if everything looks good, that itch is a positive sign. Itch means that the healing process is going on fine, and these free nerve endings are starting to repair. And itch can originate, again, due to the stimulation of these sensory receptors. So as the healing process is going, that is stimulating those free nerve endings, leading to that sense of itch. We've got acute itching, like in a mosquito bite case, or there's chronic itching, for example, patients that have eczema. And like I said, itch, there's a lot of overlap with pain due to the sharing of these nociceptors. Now for the general pathways, or the pathway of general senses. So not only pain and touch or pressure, all of them. And this side, so this part of the left side, that is known as the anterolateral system. And that system is how we transfer pain and temperature from the receptor to the cerebral cortex. While this side right here is known as a dorsal column system, and this is how we transmit proprioception, fine touch discrimination, and pressure from their receptors to the cerebral cortex. Before we go over them one at a time, a couple of things to keep in mind is that the receptors are on one side, and it takes and it transfers that action potential to the opposite side of the cerebral cortex. Okay, we have 3 neurons in each system. The second neuron is the one that will do the crossover to the opposite side. In all of these cases, there is a relay or synapse in the thalamus. That is your area of the thalamus right there. And these names, the anterolateral system and the dorsal system, those names come from the names of the white matter in the spinal cord. So the white matter, if you guys remember, there was a dorsal column, lateral column, and a ventral column. Okay, now in this system, the anterolateral system, this is coming from the anterolateral column of the spinal cord. So we'll talk about the 3 neurons. Neuron number 1, that has the receptor that was stimulated by either the pain and temperature. It goes into the spinal cord, and then it relays in the spinal cord with neuron number 2. Now, neuron number 2 crosses over to the opposite side, and then it ascends in the spinal cord in the anterolateral column of the spinal cord. It keeps on ascending in the brainstem, and then it relays to the thalamus. In the thalamus, though, this is where the 3rd neuron starts, and the 3rd neuron will take the sense to the somatosensory cortex, and because these are general senses, they will all end up going to the parietal cortex. Now, in the case of proprioception, fine touch discrimination, and pressure, it's almost the same, but just mild differences. So again, the first neuron has the receptor, taking that into the spinal cord, ascends a little bit all the way until it reaches the brainstem. Notice here there was no crossover yet. And then until it reaches in the brainstem, this is where it synapses with your second neuron. Second neuron crosses over to the opposite side and ends up in the thalamus. This is where it synapses with the 3rd neuron from the thalamus to the cerebral cortex. So again, a couple of things you want to keep in mind. The thalamus, they all had to relay there. All general senses go to the parietal cortex. Second neurons are the ones that cross over. The crossover in the case of the anterolateral system happens right here at the level of the spinal cord before ascending. While in the case of the dorsal column system, the crossover happens in the level of the brainstem with the second neuron, just like here. So the second neuron does the crossover in either cases, but it's just in different areas. Now that all of these senses have reached the parietal cortex, and to be exact, the postcentral gyrus of the parietal cortex, how are the different parts of the body represented on there? So we are going to take one cerebral hemisphere and look at it. This right here is the medial surface, and that is the lateral surface. And you can see here that the body is represented in a way where we are pretty much hanging by the lower limb and the genitals on the medial side, while the other parts of the body are represented on the lateral side. So the upper limb and hand, the face, and as you can see here, the rest of the body parts. Noticeable is that the hand and the fingers have a very specific and huge representation for general senses on the cerebral cortex. So does the face and the lips. Okay, and that shows you again why tactile discrimination is very high in those areas because of how well they are represented in the cerebral cortex. Now, I hope this theme is not true. Okay, I hope you guys are learning throughout the course. The nervous system is an amazing system. It is very interesting, and I hope you're enjoying it as much as me. And I will see you in part 3.